Good morning. My pleasure to be here today and talk to you about the Coverdell Stroke Registry. I'm Mike Frankel. I think I might have been put on the agenda into the next group in our discussion this morning, but I am a neurologist and I'm a stroke expert. I'm not a cardiac arrest expert, but I think this slide and this introduction slide highlights a picture that you might not see too much over the next 2 days, and that's a picture of the brain. And I just want to point out that it is about the brain as much as it is about the heart. And I think we lose sight of that. And we have to remember, just as you saw in some of the slides about the data collection at the national level, that neurologic outcomes are as important as cardiac outcomes. And it's not to say that one is mutually exclusive over the other. We have to really think about how we integrate these two organ systems and the outcomes and the problems that they create for us. So I do not take care of patients in the emergency room who are having a cardiac arrest, but a very famous neurologist, Walter Koroshetz, once told me that cardiac arrest is the biggest stroke you can ever have. And I think he's right. And he leads the NINDS at the NIH. Just to take kind of a bird's eye view of what we're talking about in terms of public health, and I think we kind of lose sight of this too as we have these discussions. At least in our stroke world, I lose sight of some of the bigger pictures sometimes. But at the very bottom here, you see the public health, disease surveillance, and basic science discoveries really driving what we do in the stroke world. We're fortunate now to have the NIH Stroke Net, which is a collaborative effort of 25 regional centers across the country that are working to enhance recruitment into practice-changing clinical trials. That evidence then drives what we do in terms of consensus opinion. Those consensus opinion statements are vital, and they come through the American Heart Association, the American Academy of Neurology, Neuroscience Nursing, and others. And then that drives quality initiatives, which the Coverdell Stroke Registry really is. It's a quality initiative. It is not a surveillance tool, and I will bring that up again in just a minute. But there's also other organizations like the Joint Commission that get behind these recommendations and then allow us to drive at the hospital level, as this is a very hospital-based focus for us, what we do in terms of improving the care of patients with stroke. And then at a local level, we've created a group called the Georgia Stroke Professionals Alliance, which is an educational group, nice spin-off. So really the gap that we're talking about here is the gap you're familiar with that the Institute of Medicine pointed out many years ago, that it's a gap between what we know and what we do, that there's not just a gap but a chasm, and we're trying to bridge that gap. And we in stroke believe we've made a great bridging effort with the Coverdell Stroke Registry, in large part because of our work with the American Heart Association together in Georgia, had common goals and strategies. We collect data really to improve process and outcome. This is not a disease surveillance registry. It is more of a surveillance of quality improvement, if you will. We established quality indicators that were based on evidence, and then we focused on those indicators to improve care. We are not tracking health outcomes specifically other than in-hospital outcomes, but in the new wave of funding, we are certainly trying to look beyond the hospital period into the recovery period and how patients are doing down the road so that we can effectively integrate the pre-hospital, hospital, and post-hospital settings, which I think is a very daunting task for us given the fragmentation of healthcare in this country, whether you're talking about the silos of EMS data, which it sounds like we're getting closer, to really sharing effective data, to the silos of individual hospitals and health systems, to the silos and fragmentation of our post-hospital care through practices and practice groups. We are not connected. And that lack of connectivity is really destroying what we do to take care of individual patients on a daily basis. Some of that has to do with certain rules and regulations, of which HIPAA is one of them, obviously intended to be a good thing from the get-go, but it has had side effects that we have not been successful in overcoming. So the Coverdell Registry was started in 2001 in honor of Senator Paul Coverdell, who died of a massive stroke in the year 2000. And Congress was then created a mechanism that allowed CDC to fund a handful of states. Currently, there are 9 states that are funded through this mechanism. Originally, the Coverdell Registry was a pilot prototype which we started at Emory and used it as a way to ignite interest across the state, and now it is housed really in the Division of Public Health at the state level. And we work collaboratively with groups like the Joint Commission and American Heart Association, really harmonizing our efforts towards agreeing on what is our target, what's our goal, what are the quality indicators that we want to focus on and change that will have the biggest impact. And we're, as I mentioned before, working on transitions of care, EMS to hospital and hospital to post-hospital, which we think will be our biggest challenge of all. The indicators are listed here just briefly. There is the timeliness of treatment, which is heavily focused on TPA, and I can say quite clearly if we had not done the NINDS, which is an NIH-sponsored TPA stroke trial, for TPA, I might not be having this conversation today. Really, the effectiveness of TPA drove the process improvement strategies towards getting people to identify candidates and treat patients with this life-saving treatment. When we first started in 2001, only about 15% of eligible patients were treated with TPA in the state of Georgia. Now we're over 90%. That effort took years and a lot of collaboration at the hospital level, and you can see the other categories there. We've had a number of barriers along the way to getting to where we need to be. I would say the biggest issue for us in Coverdell has been at the hospital level, is convincing hospital leadership that this is an important effort. Hospitals only have so many resources, and those resources are dwindling, and they have to have someone to collect the data, to do the real-time or concurrent data collection so that the improvement of care can be coordinated and changed. And I'd say that's been our biggest challenge. But over time, people have come to our group and wanted to be a part of it because they felt like that living in an endemic area like the stroke belt, which is where Georgia is located, there was a great effort towards common goals in that strategy. We have a lot to do in terms of collaboration. We are 68 hospitals in Georgia out of the 150 that are in Georgia. We have a lot more hospitals that we would like to work with, but we'll have to have some greater discussion about this in the workshop setting. So thank you very much, and I will stop there.
Perfect. Michael, thank you very much.